हाँ ऐसे
केम
फोन को वो मत होने दो संतोष जी, ऑन रखो ना फोन को, ये फोन को, हाँ स्क्रीन ऑन रखो ना, तो वो मत होने दो प्लीज, ठीक है, तुम्हारे हाथ में ही रखो। ओके सो या
Give me
I
1 minute.
think
Yeah.
it is streaming live on YouTube. No
Yes.
problem. And so I think we don't want to introduce anybody here, but I just want to tell something that this entire program of having this small master classes like this is definitely not my idea. This is Dr. Shilpa madam's idea. So it is her thought that, you know, you should have sessions like these small sessions, 15, 20, 30-minute sessions where you are giving specific and quick and targeted information about things which are important as far as fertility practice is concerned, and not just for super fertility consultants. It's important for people who are doing even IUI, people who are doing even just level 1 clinics. And I think it's gone off very well so far, at least because every video we have done has had more than 3,000 views, so I'm just very happy. And of course uh, once Shilpa madam decides to do something, if Nikhil Kamath can come down, then what is the problem? You know, all such things are going to happen only. So good, great, Shilpa madam. A big round of applause from all of us for doing something like this and for actually motivating me, because I am not very, as you are aware, I am not very inclined towards these type of sessions. But I'm happy that you've done this. So very nice.
Yeah, so today's session we are going to have on pre-treatment GnRH antagonists. I think
Yeah.
GnRH antagonists have been one of the greatest inventions in infertility practice, and it has made life easy for many IVF specialists. So
Yeah.
I will waste much time, and it is Dr. Jay who is one of the most informed person, as I would like to say, about antagonists. So this is very, I think, going to be a very good session, because you will hear a lot of things which you wouldn't have read anywhere or heard in any of the conferences or even in in your fellowship programs. So over to you, Dr. Jay. We'll
Yeah.
start.
So we will start off with pre-treatment GnRH antagonist. All right. The first thing which I want to tell everybody is that, the entire basis of female endocrinology, okay, the entire basis of female endocrinology is dependent on pulsatile secretion of gonadotropins. Okay. That is the most important line which you have to remember, right? The gonadotropins which come out, FSH and LH, through the hypothalamo-pituitary reflex mechanisms, they are not secreted continuously. They are secreted in a pulsatile manner. Okay. Usually it is seen that in the early phases of the follicular cycle, that means in the early follicular phase of the menstrual cycle, these pulses, okay, are slightly more frequent, but their amplitude is less. Amplitude matlab kitna takat hai, okay, how strong is that secretion impulse. All right. As we go towards the menstrual cycle, what we understand is that this pulsatile frequency becomes less, but the amplitude becomes very strong. Okay, so just keep that in mind. This is the basis why actually antagonist was introduced in the world. Okay, or for that logic, why a GnRH agonist was introduced. Any GnRH was introduced because these receptors are secreted in a pulsatile manner. So what happens is, if you have agonist or antagonist, you are destroying this pulsatile frequency. Whenever you destroy the pulsatile frequency, what it does is it causes severe reduction in FSH and LH, because now there is no pulse, so they don't really know where to secrete it from. Today you give a GnRH antagonist right now, the minute it goes and binds to those receptors, once it has gone and bound to those receptors, till the body synthesizes or absorbs these receptors inside, okay, and comes out with new ones, till that time things are blocked. So as a result of which, there is a massive sudden onset depletion of gonadotropins in the circulatory system. FSH and LH goes down drastically in an otherwise non-stimulated cycle. All right. This is the first thing which you should remember. Second thing which people should remember is that the traditional concept that, follicular recruitment occurs in the just prior to the beginning of the follicular phase at the end of the previous menstrual cycle. Okay. And as a result of which we have to start stimulation for patient on day 2, day 3, day 4 of a menstrual cycle is an outdated concept. It has been proven without doubt, okay, by multiple studies in animals, humans, mice, rat, donkeys, whatever, is that this is a continuous production. Okay, this is a continuous production of oocytes and antral follicles which is happening inside the ovary. It is up to you to decide what you want to stimulate and when you want to stimulate. So people may argue you are wrong, nothing like this actually happens. This theory does not hold any value because we have not read something like this. Very good. This theory actually never came in from gynecologists. This theory has come in from oncofertility. So when you are looking at oncofertility and a patient has been diagnosed with breast cancer on day 12 of periods, she has got the biopsy and everything done and the reports have come in and it is day 19 and somebody has decided that you need chemotherapy starting from the next 3 to 4 days. All right. So the patient comes to the doctor at day 21 of the cycle, where the corpus luteum is already present. It is a true luteal phase where corpus luteum is present, endometrium is secretory. But even then, if you put in a probe, you will see some antral follicles. Okay. And this is how the stimulation for random stimulation as well as pre-treatment antagonist actually started, where people started using antagonist just as a thing कि अरे यार कुछ तो देके start करते हैं. And people started getting excellent quality embryos. People started getting excellent quality oocytes, following which it was then extrapolated that, okay, when you have an asynchronous cohort, you can give a pre-treatment GnRH antagonist so that you can synchronize the cohort, because everybody wants to have, let's say, 10 follicles which are 17 millimeters in size, so that you get mature oocytes, so that you get metaphase 2 oocytes out of all these, right? You don't want to have a stimulated cycle where one follicle is 18, another is 21, third is 13, and the remaining 5 are 15 millimeters. That is an asynchronous cohort. No, none of us like to have that, correct? Which is why this pre-treatment antagonist was introduced. Okay, so I will draw something onto the board. Let me just try to share the screen. Guys, stay unmuted, okay?
Yeah, visible.
Visible, right? Okay. See. So we are actually taught traditional. I'll just write down traditional in green color, and I will write down concept in red. Okay. So what are we taught traditionally? That when you look at the ovary, okay, there is a pool of antral follicles which are recruited, okay, under hormonal effect, obviously, of the hormone FSH. Okay, one guy is going to become the dominant follicle, others are going to become atretic. Okay, of course, then there is this entire cycle of FSH where it goes to become the dominant follicles, and then there is ovulation. Okay, but we are predominantly worried about this pool. Okay, so what is the new concept? This new concept is very, very simple. It tells that irrespective of the cohort which you are trying to see, even when it becomes this, there are these atretic follicles, but simultaneously there are these other follicles which have been freshly recruited. Even when this guy becomes the dominant follicle, there are some atretic follicles, okay, which have undergone atresia, but there are going to be other follicles which are freshly recruited. All right, so irrespective of the timing of the menstrual cycle, irrespective of the timing of the menstrual cycle, you will be able to stimulate this cohort. Okay, irrespective of the presence of this guy, irrespective of the presence of this guy, or irrespective of the presence of this guy, you will be able to stimulate. What is it that we are predominantly trying to achieve by giving somebody a pre-treatment of antagonist? Okay, now please remember, this pre-treatment of antagonist is only applicable if you are doing freeze-all cycles. Okay, that means if you are starting stimulation on the 14th day, endometrium is already out of sync. Okay, you cannot really say that I want a fresh cycle also with a pre-treatment random start GnRH antagonist. That is not possible. You need to have an extremely strong freeze-all program for you to do any of this in situation number 1 or situation number 2. If in case you are worried that no, I want to do a fresh transfer only, then the pre-treatment has to be given on days 1, 2, or 3, or days 1 and 2 at the start of the menstrual cycle, and you have to give an HCG trigger, and then you are supposed to do a fresh transfer. It's very, very simple. But in all other circumstances, if you are giving pre-treatment, let's say from day 8, let's say from day 14, let's say from day 13, in all these situations, this becomes a random start protocol. This is a random start. And whenever you are doing a random start, the most important thing is you are supposed to do freeze on. Okay, that is a very, very important take home point, because endometrium is out of sync. Okay, now comes the question that why should you give GnRH antagonist only? Okay, why GnRH antagonist, and why should I not give estradiol valerate in the previous cycle? Why should I not give OCPs in the previous cycle? Why should I not give anything else? Why should I not give regesterone in the previous cycle? Why? Why is it that Jay is favoring GnRH antagonist? Does he have some stake in the company who is manufacturing it? Okay, so the answer to that question is very, very simple. Definitely, I have no stake in that company at this point in time. But what is important to understand is GnRH antagonist is something which then gets washed out of the system very, very fast. Okay. Today, you give one dose of GnRH antagonist within 18 to 19 hours, it is going to be washed out from the system. As a result of which, you need to daily administer a GnRH antagonist. There is no GnRH antagonist depot which is available, that one GnRH antagonist you give, it is fine for 25 days. There is no such thing which is available, right? That is the first thing. Second, this guy predominantly goes and acts onto the GnRH agonist receptor. Okay, it does not go and act on FSH receptor. It does not go and act on LH receptor. It does not go and act on estrogen receptor. It doesn't really do any of it. Okay, this is the only molecule which acts predominantly onto the source. Okay, everything else, estradiol valerate, if you want to give pre-treatment, let's say you want to give from day 21 to day 29 of the previous cycle, when you call the patient, what is going to happen? Try doing serum estradiol of that patient. The value will be 250. Okay, then you will be worried, array, it is 250. Now, how do I stimulate this? For that estrogen receptor to become free, you are going to require a very high dose of your gonadotropin for the next 4 to 5 days. Okay, as a result of which, as beautiful as it seems, it is not very popular. So, okay, simultaneously, when you are looking at OCPs, it has been proven without doubt that when you have prolonged oral contraceptive pills to suppress and to get a synchronized cohort, it causes severe downregulation of FSH and LH receptors, thereby causing you to use more gonadotropins. And simultaneously, because LH receptors has been downregulated by oral contraceptive pills, pre-treatment with oral contraceptive pills definitely gives rise to a poor quality oocyte. Okay, there is absolutely no doubt in that fact. Okay, then comes the third thing, which is progesterone. That is regesterone, dufastone, whatever you want to give. But that is predominantly more for cycle regulation. That much dose of progesterone has got no effect on the FSH secretion. That much dose of progesterone has got no effect on the way in which the cohort is recruited. When you consider all the options which you have pre-treatment, the only person which fits all the tick marks and gives you convenience is your GnRH antagonist. As a result of which, it is a very popular protocol. Okay. Now, how do we use it? Okay, what is it that we should keep in mind? How many doses to give? Why to give only 2 doses? Why not 3 doses? Why not 4 doses? Okay, simple. Don't go by that logic in your life. Okay, decide which are your holidays first. Okay, let's assume you don't want to work on Saturday, Sunday. Myself and Kiran Kurkoti sir are very good friends. We decided that this Saturday we are going to have a pot party in Pune. No problem. Okay, give one additional antagonist to that patient to ensure that उसका sonography भी नहीं आएगा Saturday को. ठीक है, sonography आएगा तो वो report भेजेगी ना. So you can easily give anywhere between 2 shots to 4 shots. So what is your liberty? Your liberty is of 48 hours. You have a liberty of 2 days. Okay. There are people who say, no, minimum 3 dosages is enough. That is not correct. That is absolutely not correct. There are many people who say, but I don't have an asynchronous cohort only. All the antral follicles which I saw on day 2, everybody is 2 to 4 millimeters. Understanding, not a single follicle is 5 millimeters. Then why should I give pretreatment antagonist? Then give pretreatment antagonist so that your pickups don't come on Saturday and Sunday. Very simple. Okay. It doesn't really affect anything. But let's say you have one follicle, which is 7 millimeter antral follicle count. Estrogen is 51.4. Okay. And you have another 4 antral follicles, normal responder. I'm just talking at this point in time. You have another 4 antral follicles, 4 on each side, 2, 3, 4 millimeters, whatever. In this situation, that 7 millimeter person. Okay. So I will just again draw this and explain, because it's very, very easy to understand once I draw it for you. So again, I'll go to the whiteboard. Okay. Shilpa madam, visible, right?
Yes, yes.
Okay. See, in this situation, when I draw the ovary, the patient has come to you on day 3. She was busy on day 2, very busy, occupied, so she could not come. You have antral follicles like this, and ek bhaiya you have, which is around like this. Useless guy, around 8 millimeters. Chalo, let's complicate it. 8 millimeters, everybody else is 2 to 4 millimeters. Okay. And now you are worried that this 8 millimeter guy, okay, would have already secreted. Okay, this guy would have already secreted FSH and then would have caused enough estradiol production to go to the hypothalamus. Okay. And FSH causes more FSH receptors also to happen on this. So, iske wajah se all these guys will become apoptotic. Okay. And at the end of your stimulation, you will have an iatrogenic poor responder that you did not monitor this. And you, instead of getting 7 oocytes, you got only 2. Okay. So, what do you do in this situation? In this situation, your best thing is to give a GnRH antagonist. Okay. So what will this GnRH antagonist do? See, this GnRH antagonist, poor guy, will do nothing to these guys. It will do nothing to these guys, but to this person, but to this gentleman who has become 8 millimeter in size, it will go and ensure that there is no FSH which is coming to bind to these receptors. So this guy will become apoptotic. By the time it becomes apoptotic, you have a fresh recruitment which would have already occurred in that same ovary. So what happens is this 8 millimeters, when you come back, when you do tell the patient day 2, day 3, day 4. Okay, so but this one has come on day 3. So day 3, day 4 and day 5. 3 din antagonist low and come back to me on day 6. On day 6, when you look at this ovary, it is going to be like this. This follicle would have become something like this. And you will have a fresh set of antral follicles, but you are not aware that it is not these ones. These ones are gone. A fresh recruit has occurred. On day 6, when you start the patient on HMG, RFSH, whatever you love the most, okay, it will end up recruiting these follicles. Okay. And when it recruits these follicles, you are going to have, then after 5 to 7 days, these follicles becoming big, and you will think that, oh my God, your GnRH antagonist has actually done wonders and would have done something to the development of this follicle. But whereas in real life circumstances, there is no such thing which happens. This guy is gone. The fresh recruits which have come in are the ones which gets actually stimulated. And because these guys get stimulated, you get a synchronized cohort. And that is something which is very, very important for you to understand when you give pre-treatment antagonist. This same thing you can extrapolate on day 8. Let's assume on day 8, you have a follicle. Now, instead of 8 millimeters, it is 14 millimeters, right? And the patient is telling you, boss, I am in India only for 18 days. तेरे को मेरे को stimulation करने का है कि नहीं करने का है? Simple. Okay. In that type of situation as well, you will do an estrogen. Estrogen will be 185. Okay. So you will be like, अरे definitely estrogen is 185, endometrium is triple line. अब क्या होगा? You know. In that also give antagonist. Pre-treatment antagonist does not mean that you are supposed to give it on day 2, day 3 and day 4. It means pre-treatment. Treatment can be on any day. Understanding? In that situation also you can give this antagonist for 2 to 3 days. Usually for that follicle, agar tum wo usko khana nahi doge na, that follicle will automatically not have anything to secrete more. Okay, a fresh batch of recruit will come and you will be able to start it randomly. Okay. If you are very worried, ab kya hoga? In that situation, let's say a follicle is 18 millimeters and you want to do this pre-treatment, you are very worried. Don't be worried. Aspirate the follicle. So you have apoptosed it. Understanding? Oocyte bahar aa gaya, even if it is immature, let discard that oocyte. Give antagonist for 2 days. जो कुछ भी उगने वाला है वो भी नहीं उगेगा. And you will have a fresh recruit of oocytes which is coming in, and that oocyte which you are then going to stimulate with your pre-treatment antagonist. All right. But please remember, this is when you are doing freeze-all. You cannot apply a pre-treatment antagonist to your IUI cycles. This is not for IUI cycles. This is not for natural cycles. Okay. You have a follicle on day 3 in an IUI cycle at, let's say, 8 millimeters. Okay. Do an estrogen. If the estrogen is less than, let's say, 50, start off the stimulation, because any which ways you just want 1 to 2 follicles to come in. And once you get this 1 to 2 follicles, it will not affect your cycle outcomes. But no point in giving pre-treatment antagonist at IUI or natural cycles. All right. In those type of situations, it is not recommended. It is definitely recommended. The best role, from at least from what we see and do, we do a lot of random start stimulations because we do have a lot of international patients coming in. And when we have international patients, even if you try to match everything, what if the period comes 5 days before her flight tickets? Na? You can't really prepone all that. So in that situations, random start protocol with GnRH antagonist pre-treatment is absolutely fabulous. Okay, absolutely fabulous. Second thing where it is fabulous is, I'll give you my practical problem. See, I am traveling on quite a lot of times on Thursdays, okay, to do surgeries outside Mumbai. Sometimes there are some people who love me so much that they will call me on Wednesday as well. That you do one thing, you come Wednesday half day. As soon as you land, we will start doing 10 cases through the night. Next day, you will sleep for 2 hours, wake up in the morning and another 10 cases. Okay. So in that situation, what happens is I don't want my patients predominantly to have their oocyte pickups, the one who really want to see me only, okay, to come on that Thursday. Okay, in that situation, we add that pre-treatment antagonist to these patients. Okay, and when we add this pre-treatment antagonist to these patients, it is something which is really wonderful. It really works beautifully well. It really helps these patients, and it gives you a synchronous cohort after your pre-treatment antagonist. Okay, now one more thing which I want to add, and which is again very, very important, which I think people don't understand, is that you can actually add 2 shots of GnRH antagonist on a same day. 12 hours apart. Okay. Morning you give, evening you give. There is no, of course, the science and literature is very strong that once in 24 hours is more than enough. But in special circumstances, when you have 3-4 follicles which are there, okay, which have already, let's say 13 millimeters, 3 follicles. Okay. In this type of situations, you can give 2 shots of antagonist on the same day, 2 shots of antagonist on the next day. कुछ भी रहेगा ना वो साफ हो जाएगा. Trust me, it is very, very, very luteolytic. That thing can cause severe apoptosis of those follicles if you are giving it in a window of 48 hours. Okay, this is just a practical point. I don't really know if there is any fertility journal which is mentioning anything like this. But in a normal situation, instead of a single shot, if you give 2 shots, when you have multiple follicles which are out of cohort, 13 millimeter का 3 follicle, 8 millimeter का 4 follicle, 4 millimeter का 5 follicle, something like that. Okay. In that situation, give a double dose of antagonist, because single dose of antagonist may or may not be able, or may not be capable of holding on to those follicles because of the mechanisms which work. There is a lot of molecular insights into these mechanisms. It is not very straightforward that FSH goes there, and estrogen also goes there, and it causes receptor feedback, and then GnRH secretes a pulse. It is not so easy. Okay, the molecular mechanisms in which the secretion occurs through the hypothalamo-pituitary tract is very, very complex. We can have 5 sessions on that. Okay, just on how FSH is secreted, how LH is secreted, and all these things. But for practical purposes, just remember this. Okay. Okay. Apart from this, when we try to mention that, can we combine it? Matlab, can we combine estradiol valerate first, then give GnRH pre-treatment antagonist? Okay. And then can we do the stimulation? You can do that, but it has got no role, because that circulating estrogen from estradiol valerate any which ways, okay, is not going to cause receptor secretion at GnRH level. When you have circulating estrogen, no, it is a negative feedback on hypothalamus. So GnRH receptors are not secreted. So there is no point honestly doing that. Third, people ask, okay, you mentioned 2 to 3 days. Can we give it for 5 days? You know, I am not available for 1 full week. मैं पूरा week ही बाहर हूँ. Can we give it for 5 days? You can, but rather than giving it for 5 days, it's very simple. Come back from your vacation. Even if the patient is on the 13th day, 14th day, somebody is on 18th day, somebody is on 21st day, do a random start with pre-treatment antagonist for all of them, freeze all, and then transfer the embryos. Na? Why to waste your money in giving this antagonist like this? Okay. Another thing which people ask is that if we are giving a GnRH pre-treatment antagonist, can we use the PPOS protocol? I think there is beautiful hype about the progesterone protocols, that I give Meprate in the morning, I give in the evening, I give 5, I give 10. Very good. It's very nice. Okay. If at all by mistake, you end up doing your own embryology as well. Okay. Believe me, out of 10, in 4 occasions, your embryologist is going to come and tell you, "Arey boss, ye kya kiya tha?" The cumulus was very sticky. Okay. The reason why the cumulus is very sticky in that protocol is not because your stimulation was wrong. It is because that progesterone balance which it strikes at the end, at the end when the ovulation is about to mature and all these things, this progesterone is not something which goes off, washes out of the system. It is a steroid. It takes some time to wash out from the system. So it does not allow the cumulus to lyse very effectively at that final day. Understanding? And as a result of which you will have good oocytes, but that cumulus will become very sticky. Your high-lase time will go up. And because your high-lase time goes up, you may have good blastocyst embryos, but it may end up with higher rates of abortions. Again, this is not mentioned in any paper. I don't want to argue, challenge, or fight with anyone on this. This is just my observation as far as PPOS protocol is concerned. It is not that we've not tried it. We have done more than 350 cycles consistently when antagonist was shortage in India. Okay. In that time, we have done 350 stimulations on PPOS protocol. So this is our experience from that. Obviously, we've not published it, but this is just a practical experience which I wanted to share regarding this. So with this, if there are any more questions on this, I shall be happy to answer. And, whatever people want, we can answer. No problem.
Okay, so you can end the YouTube the recording.
Yeah, we can answer questions, 2-3 questions there and then end it. It's absolutely okay.
Okay. So I will just stick to this routine stimulation, not the random start stimulation, just a routine stimulation on that we are doing. And you say that you give the antag on day 1, day 2, day 3. So have you noticed that giving this has increased the dosage of gonadotropins which are required in that cycle? Okay.
No.
Do you stick to the fixed protocol of antag later on, or is flexible better?
So we mandatorily give it on day 6 of stimulation. Mandatory. Okay. So we have a fixed protocol for giving GnRH antagonist in the cycle, and we fixed it at the 6th day. Okay.
So usually the stimulation will take about, say, minimum 8 to 12 days is what roughly it takes. So
10 days.
10 days, roughly 10 days. So you would have given 5 doses of antag.
4 doses, 6, 7, 8, and
9. So that is how you would have given. Plus adding these first 3 doses of antag. So there will be about 7 doses of antag total in that cycle. Does it cause detrimental effect to the endometrium if you are doing a fresh transfer?
The first thing which I actually mentioned in this entire thing was, this is the best thing when it works when you want to do a freeze all cycle.
No, that is random start. I'm talking
about any start. See, even if you want to give pre-treatment antagonist, all right, for a particular cycle, you want to balance out the cohort, right? That is like people would say that I don't like to give pre-treatment antagonist in every cycle, for example, correct? Nobody likes to give it. You can give it in PCOS patients as well, honestly. And it will work beautifully well in PCOS patients because PCOS patients have the maximum irregularity in the cohort. Some follicles are apoptotic, some are fresh recruits, some are recruits which have a high androgen. In all situations, even in PCOS, it will work very nicely. But yes, if you are giving pre-treatment antagonist, for me at least, for me, I don't like to do a fresh cycle in that particular cycle. One may do it, there are people who have done it, papers have been published, they've got some outcomes, but I don't do it. I find it very impractical. And I think freeze-all is a very simple, safe, effective, 100% sure option. So why to have that, see, when people try to talk that I do a fresh cycle because, time to pregnancy goes down. Abbe, in 1 month, what time to pregnancy will go down? School ka admission bhi delay nahi hota hai, in that much. So nothing, patients really don't bother about all these things.
Okay. Yeah, so usually you prefer this in poor responders where there is a lot of variation in the cohort size, or
it will work the best. It will work the best when antral follicle count is less than 10 with an asynchronous cohort, right? But as I said, you can use it in normo responders when there is random start. You can use it in hyper responders when you want a random start. You can use it wherever. But if you want a routine stimulation to start during menses, then it will work the best when you have poor responders with asynchronous cohort.
Yeah. So I think yeah, I'm done with my questions. So shall we take the rest of the questions on the WhatsApp groups?
Whatever Kiran sir says or whatever Dipesh bhai says, no problem.
No, take it here, man. A lot of people are there.
No, there are no questions. So random start, would you prefer any time of the cycle?
Yeah, that is why it is random.
Is it okay if AMH is slightly lower and age is 35 for the antagonist?
Yeah, how does it matter?
So is it not a good practical tip to use pre-treatment antag for every antagonist cycle, as it will give even cohort of follicles?
It is not a good practical tip. It is actually not needed. Quite a lot of times when what is going to happen is very simple, right? When the cohort itself is very synchronous in front of you, unless you want to do this adjustment of Saturday, Sunday, as I mentioned, right? Otherwise, it really doesn't matter. And these days it is a big fad, yeah. A lot of fertility consultants like to post it on Instagram that they did a pickup on Sunday. So for those people, pre-treatment antagonist is not recommended at all. Keep doing pickups Saturday, Sunday, Monday, no problem.
Okay, Jay, one more practical question. Do you increase the dose of antag once the follicle crosses 13, 12, 13?
No. Oh, antag is such a powerful molecule. 0.25 amount of antag is maybe 10 times or 25 times more the dose which the body actually requires to fill up all receptors present anywhere in the body. In fact, in the whole building's body. It is not really required. What typically is a big problem with antagonist, or as far as you will always have people who will say, oh, I know antagonist acts for 18 hours. Somebody will say, no, 24 hours. Somebody will say, no, 31.3 hours. Array, listen, it is not dependent on that. It is actually dependent on which raw material you are using. Okay. A lot of people don't know this. There are just few people who supply the raw material for producing the antagonist the way we produce it. Understanding? And as long as that raw material is not screened properly, if there is an impurity in this raw material, you are going to have an offshoot somewhere or the other. Okay. But of course, that is beyond the realm of discussion for this particular situation. So we are not discussing that.
So antagonist pre-treatment contraindicated in any group of patients?
In patients in whom you have given a GnRH agonist depot prior to starting, or if you are using long protocol, IUI patients, definitely no role.
Okay, so
patient has to go abroad. How many days minimum stimulation in random start? Maybe 10 to 11 days is standard. I mean, it really doesn't exceed that. It doesn't exceed that.
Okay. I think, yeah, we are good. So we'll take the rest of the questions on the WhatsApp groups.
WhatsApp.